Thank you very much, Anne. I also would like to echo Robin's thanks to the Region of Waterloo and to the Crime Prevention Council for hosting us today and for giving us this opportunity to discuss this extremely important issue. I have been the coordinator of the Healthy Child Development Improving the Odds program for the Ontario College of Family Physicians since 1999, and we run a variety of workshops on all issues that are related to child health and developmental outcomes, and what family physicians, nurse practitioners, and other primary care providers can do in the preconception, perinatal, postpartum, and during well-child visits to improve developmental and health outcomes for children. So I'm going to be looking at some of the interpersonal violence strategies, looking at pregnancy and well-child visits for impacting infant mental health and child developmental outcomes. So this is the first slide, and if you think about what we talk about in primary care, we have the mother's health in terms of her genetic history and her periconception health, and all sorts of factors like substance use and mental health issues, and her environment can make a huge difference. So the environment a woman lives in while she's pregnant, the stresses on her, her anxieties, if she's exposed to interpersonal violence, can raise her adrenaline levels, it can raise her cortisol levels, and that can affect the biologic environment that that fetus is growing in as it develops. You talk about the birth, the transition, the sleepless nights, adjusting to the increased demands of caring for a newborn, and that can be a point at which interpersonal violence can increase and escalate because of sleeplessness and increased stress and conflict and changing roles. You look at the time from birth right through to the early years in school entry, and we're fortunate in primary care that we have multiple opportunities to intervene to help. And if you think about a practical tool like the Rourke Baby Record, right on the record there is bolded as high evidence to screen for high-risk infants that might need a home visit need by a public health nurse visiting. And some of the high-risk things are domestic violence and interpersonal conflict and poor marital relationships. So whether it's a same-sex couple or a different heterosexual couple, you need to screen for and look at that, and that's all built into the Rourke record that we use. This slide is a very interesting one that looks at brain development. So we know that the fetus's brain is developing up until birth, and that after birth the dendritic connections are being formed. So we have the major senses like vision, hearing, and touch. We also have sleep and wakefulness, but social relationships, shared attention, some of the mindfulness, the mental functions in the frontal lobe, critical thinking, and reflective linking all develop at different stages. And we know that the environment that the child is growing up in can impact those dendritic connections. And if that child is stressed, the increased cortisol levels can actually cause cell damage, smaller hippocampus, and alter that child's behavior, learning, and ultimate health. We do know that you have your genes, but that the environment can affect how those genes are turned on and turned off, and can actually cause long-term changes to the DNA through that mechanism. So there are all sorts of different biochemical things, but it's a switching on and switching off, and we call that epigenetics. So stressors like abuse or poor nutrition can certainly activate epigenetic marks, modifying histones, changing the way things chemically are managed on the DNA strands, which can affect the proteins and the future generation's health. So that's a very important biologic factor that we're starting to recognize more and more. The American Academy of Pediatrics came up with a technical report looking at the lifelong impact of early childhood adversity and toxic stress. And they came up with an ecobiological developmental model that looked at the interaction of epigenetics, the life course, the physiologic impact on the child, and looked at the long-term learning behavior, physical and mental and well-being. The Canadian Pediatric Society has recently adopted an early years platform to look at this, and now even the Royal College of Physicians and Surgeons have an early years committee and will be looking at how to integrate education of their members, because all bodies are looking at this as ultimately important for adult health outcomes. This is a lovely visual that tells you that a little bit of stress, when the child is well supported and has a resilient adult present to help them learn new skills, can heighten their sensitivity, improve their memory, their competence, and their coping skills. However, imagine a child in a home where interpersonal violence, domestic violence between the adult caregivers, whether they're mother and father or same-sex partners or other caregivers. Look at what happens. You get hyperarousal. That child, even if they're not directly exposed to the violence, are impacted by it. Their adrenaline and their cortisol systems are elevated. They have dysregulated catecholamines. They become hypervigilant, hyperreactive, and go into survival mode. And that will then be re-triggered with even slight stressors later on. We know that long-term studies are showing that disease risk happens, increased. There's reduced learning because that child is so stressed that they can't focus, and they have impairments in their socialization because often mothers who are being abused are often socially isolated. They withdraw. They may not be feeling well physically or emotionally, and that can impact their ability to optimize their mothering of their children. What is infant mental health? Why are we talking about children? Well, it's the social, emotional, and cognitive well-being of infants and toddlers. And we know that it begins at conception. There are long-term mental and emotional problems that can happen. And sometimes poor mental health is not just about what the child is exposed to, but also the absence of those normal, joyful experiences. Children need to be played with. They need to have good, healthy relationships. And when a child is exposed to a family environment where interpersonal violence is happening, this can impact them through the loss of those normal bonds, relationships, and opportunities to learn. We know that children don't come into the clinic saying, I'm living in a domestic violence or interpersonal violence situation. They present with sleep or eating problems. They may have toileting issues. They may be withdrawn or clingy. They may have difficulty separating from their caregivers. They may have new fears. They may regress developmentally. They may become aggressive, and they may play out the violence that they're witnessing in their peer groups with other children at daycare or play groups. They may be anxious as they get older, and they may exhibit classic PTSD syndromes. They may have poor attachment. They may become depressed themselves and have dysregulated stress systems. As teenagers, they may have very low self-esteem and form relationships with new partners and then repeat the cycle of violence in their own adult and teenage relationships. Children may also become preoccupied with traumatic events and may bring that episode up frequently. So this is a nice graphic that looks at how traumatic events coupled with limited protective factors may lead that baby or toddler to be unable to recover from the trauma, and that may lead to poor mental health in the infant or toddler. And so this is something where there's ongoing abuse. We know that many times there are multiple episodes of abuse before a victim, a woman usually, is able to leave that relationship. And think about what happens if the woman is killed, which is sometimes an outcome, a tragic outcome, and if that child is left with the abusive parent and there are no supports from nurturing and loving caregivers. So this is a really difficult situation for that child. Now, if we are able to intercede and provide good, resilient caregivers, if we're able to support that family system and make sure that the child's needs are looked at in that system, we can have good factors that will mitigate or minimize the impact and allow that baby or toddler to hopefully recover from that traumatic experience and event. And that's why we now have child protection laws in Ontario that look at interpersonal violence as a risk factor for children. So trauma leads to stress, which affects brain development, overall development, the relationships and attachment relationships that child has with their caregivers, and long-term their overall health and well-being. Children need nurturing, loving environments for healthy development, and this graph comes from the National Scientific Council on the Developing Child and shows that when children are exposed to 1 to 2 risk factors only about 10% have potential developmental delays. But when you increase the number of risk factors, and if you think of interpersonal violence, you have the witnessing of violence, you have a parent who is preoccupied and stressed by the violence. That parent may develop mental health or substance use issues. There may be ongoing abuse, there may be isolation, and there may be other factors such as a lack of caregiving and nurturing. So it's very easy to get to 7 risk factors. Those children have a very high risk of developing developmental delays, which can then impair their abilities to form healthy, long-term relationships, have good school success. So we need to move beyond just surveillance and physical care for children at well baby visits. We need to counsel and look at some of the issues and try to identify that as an opportunity to screen for interpersonal violence. Think about and discuss risk factors. Consider your referrals. If you need to, you can always call Child Protection Services anonymously to ask. And if there is a separation and if there are court charges pending, supervised access visits, support through mental health programs, through social work, through shelters, for the families, for the mothers specifically. We know that we can provide community support through public health home nursing visits, and we can provide early intervention referrals for those children to help them recover when they have witnessed. So we need to start thinking about the child, look at what's going on, and recognize the impacts. So doing a family assessment, looking at other sources of stress that can build resiliency and support for that child. Consider public health in terms of support. Look at the role of child protection if required. Make sure that you give information about shelters and emergency agencies. We do our full physical, but you can also, if there's a situation where an abusive parent has unsupervised access visits, then that could also be used in terms of control. Many abusive partners will use the parent-child relationship as a form of emotional control, and that's something that you need to look at. And if required, you can look at family and play groups, respite care, and social work referrals for financial and housing issues. Remember to do a comprehensive assessment, and one tool that has been developed and has been adopted by the College of Family Physicians, the Society of Obstetricians and Gynecologists, and the Midwifery Association, as well as all of the nursing associations, is the ALPHA tool. There are 3 key questions. Have you ever experienced abuse? Are you or have you ever been afraid of your partner? And are you safe? Those are simple questions that can be integrated into any well-woman visit. The ALPHA forms were developed specifically for use in pregnancy, have been validated and are evidence-based. They're recommended to be used after 20 weeks, but really you can use them almost at any time. There is both a provider version as well as a self-report version for the woman to complete in your office. But remember, do not send it home with her, because if she's living with an abusive partner, whether male or female, that sending home of the form can sometimes trigger an abusive event. In many of our clinics, we can bill for the extra time that's taken to go over. And as Robin already mentioned, be sensitive to cultural issues and use non-family interpreters to protect that woman's confidentiality. Associations don't imply causality, so some of the factors are family factors like social isolation, recent stressful life events, and poor couple relationship. Maternal factors such as her ability to attend prenatal care, attend prenatal classes, her feelings about the pregnancy, her relationships with her own parents, her self-esteem, her history of depression, and in particular whether she's had any depression during the pregnancy. Substance use is another psychosocial factor, and then there are specific questions about family violence. Some of the adverse outcomes that can be identified by using the ALPHA include woman abuse, child abuse, couple dysfunction, postpartum depression, and increased risk of childhood physical illness. So the ALPHA forms themselves, these are the questions around social support. How does your partner feel about your pregnancy? Who will be helping you when you go home? What changes are you planning? How would you describe your relationship? And what do you think your relationship will be like after the birth? So as you can see, they're very easy questions that you can use to engage your patient and discuss different concepts. As you get into questions about emotional issues, depression, how did you get along with your parents? Did you feel loved by your parents? What concerns do you have about becoming a mother? Have you ever had any issues? How has your mood been during this pregnancy? Questions about substance use. The CAGE is the classic questionnaire, but in pregnancy, the recommended questionnaire is the TACE, where you ask about tolerance, annoyance, whether the woman has been recommended to cut down, and whether she needs an eye-opener. And so we'll be making this ALPHA questionnaire available to you after the talk today through the website. These are the detailed questions around family violence, starting by talking about the parent's relationship and then moving into your own. Some of these questions are very similar to the ones that you've seen from Robin. And questions like, do you ever feel frightened by what your partner says or does? Have you ever been forced to have sex against your will? Questions about discipline. How were you disciplined? How do you think you will discipline? Because we know that sometimes there's generational reactions and parents will parent the way they were parented. So one of the things, again, getting back to primary care, we know that we are the professionals that see women and children at regular intervals. We can provide them with insight into the impact on her child and help her reach out for support. We can also observe how those parents react at times of stress, illness, immunizations, see how they comfort and nurture that child as a window into the family dynamics. And we also can ask questions that they will welcome. And many women will say that they didn't know that their family doctor was even interested in providing issues around interpersonal violence, and that they appreciated the fact that we can provide a confidential and non-threatening environment. We can also document in our chart any physical injuries so that later on, if there are court issues that come up, that information is available to that woman. So to summarize, if we have a normal, healthy child growing up in a nurturing, caring environment, that's our ideal. But put that healthy child into a dysfunctional environment, witnessing interpersonal violence, and you have risks for that child. Take a child with any developmental or chromosomal or birth problem, a premature infant, a child who's delayed, and give them a nurturing, supporting environment, they have an opportunity to thrive. But if they're growing up in an environment where there's conflict and stress and abuse and depression and poor relationships, that child is extremely high risk. And the concept of epigenetics tells us that nature and nurture are continuously interacting, and that we need to look at that relationship and help the victim of that violence find supports and help improve outcomes for herself and for her children. That's it for me on my slide, so I think we now have lots of time for questions.